Hello friends, welcome to Creative Medicine. In this lecture, we will learn about
Persistent anovulation not treated leads to all except persistent anovulation if it is not treated. Persistent anovulation is PCOD. In PCOD, there is increased hirsutism, endometrial carcinoma, and increased risk of cardiovascular diseases is seen. Ovarian carcinoma is not seen. Okay. Next. 20-year-old average weight female presents with oligomenorrhea and abnormal facial hair growth along with high levels of serum testosterone level. On ultrasonography, ovaries are normal. The diagnosis is here the patient has abnormal hair growth, that is the patient has hirsutism with high free testosterone levels are seen. On an ultrasonography, the ovaries are normal. Though the ovaries are normal, the patient with oligomenorrhea and serum free testosterone level high, we can classify the patient as polycystic ovarian disease. Why? Because there is a criteria which is called as Rotterdam criteria. In Rotterdam criteria, according to this, we have three criteria. One, there is oligoanovulation. Second, there should be clinical and biochemical signs of hyperandrogenism. And third, polycystic ovaries should be there in the ovaries. Many cysts should be there in the ovaries. So this patient will will have the first one, she is oligomenoric and she also has hyperandrogenism by increased free testosterone. Only 2 out of these 3 should be positive. So Rotterdam criteria, if 2 out of 3 is positive, then you can label the patient to be polycystic ovarian disease. So here the diagnosis is polycystic ovarian disease.
thank you and thank you for watching.